Okay. And good afternoon, everybody. And for those who are joining us at this time, we've just admitted everybody from the waiting room. So it does take a minute or two for everybody to get on in. And so in the meantime, my name is Dominic Zerlo, and I am with the New Mexico Department of Health. And we are here, the Department of Health is here to help assist administratively with the committees that were started by the Medical Psilocybin Advisory Board. And the chair of this particular committee is Dr. Larry Leeman. So with that, Larry, I will turn it on over to you. And as mentioned, we do have our staff that are here to help with muting and unmuting individuals and with moving any technical issues. We'll be happy to help as we can. So thank you very much.
Great, thank you, Dom. Good afternoon, everybody. Good to see so many of you here. It's great. I'm just going to we'll summarize where we were at the end of the last meeting. We had agreed on like 7 main areas of scope that we're addressing, and those included everything from training, care plans, and such. We had made a decision that during each of our meetings, at least for the next few months till we saturate our own education, that we were going to have speakers either internally or externally that are going to help present information so we can all get that. I think I'm going to share a little bit. So that we're going to have Chris Caldwell. Chris is actually a leader of End-of-Life Psychedelic training. She's located in Boulder as a professor at Naropa. She's going to be doing some focus with us in a little bit later. We'll get started. And Chris is going to focus on, we talked some on the role of like the care team, the facilitators, and role of the care plan, which were 2 of the major issues. I've had conversations with people about several other things that are planned for future meetings. I'm going to share those and then kind of ask people to, suggest what else do they think would be helpful for this committee to people to get on the same page. So we have a plan for one of our internal members, Jen Clement, to talk about psychedelic chaplains, the role of psychedelic chaplains. James Brown, who I see is here today, is going to give a talk at a later point on really kind of pharmacological issues that are more common in people that have end-of-life issues, cancer, altered metabolism. We're hoping to have actually people to talk that are actually working in sort of a psychedelic doula role, to talk a little bit about how it works to have multiple people there potentially, in other words, partners and such there. But we're very open. I mean, we have room for other people to come speak. So if people have some thoughts when we go into the comment phase in a little bit, love to hear thoughts on what other areas would be helpful to us. And again, our main focus is to accumulate the information that we need to make additional recommendations on those seven scope areas. So having said that, I think it'll work. Can we do both committee? Here's a question so is there a difference between public comment and committee comment? Is there a difference there? Not really.
No, Larry, you can just do that as you wish. It can either be during the meeting for this, or you can do it at the end. So that is however you would like to set it up.
Okay. Well, right now, we'll call this during the meeting. I'd like to have thoughts on other areas that would be helpful for committee and public members regarding end-of-life care. I mentioned about 4 or 5 things, but I'd love to hear people kind of raise their hands and have some other thoughts, and we can have those set up. My goal actually is over the next week or so to actually set up a little bit of schedule so you know that, and the idea that would be probably about 20 minutes at each meeting, and then I think that'll be a good way to sort of spark conversation and give us some background. We're also going to have one committee member is going to give us sort of an overview of where programs are, where research is at. So we're going to try to cover those, but I'm sure there's other areas that I haven't thought of, and would love to hear people's thoughts.
Okay, and we have a request in the chat if we could please post the 7 topics.
Can. Dom, do you have easy access to the PowerPoint that
I,
we did last time?
I am going to it right now to get it to copy and paste.
Awesome. Appreciate that.
Yeah, just give me a minute to be able to get there.
Thank you, gentlemen. So again, if you wish to speak, go ahead and please raise your hand. That way we can go ahead and enable your microphone credentials. If you are on the Teams app, it'll be a hand icon that you can select. If you're on the phone, you'll have to hit the menu, which could usually look like 3 dots. And if you're joining us on telephone today, it's going to be *5. First up is Don. Don, I've enabled your microphone credentials. You may unmute yourself and begin when you're ready.
There, is that better? Can you hear me?
Yes, sir.
Great. Well, I just want to, I've got stage 4 prostate cancer, and right now my health is pretty well because the medicine is working. But if this starts to go, hopefully it won't, but I want to be, to say that it's the mental with that is an issue for those of us that have cancer. I can only imagine if you're dying, this medicine needs to be used to help our mental and emotional fear of all of this. We also, in my opinion, need to figure out how far advanced do we start to, I don't want to, I guess the word administer psilocybin to somebody with cancer who is coming to the end of life.
Don, this is Larry Leeman. Am I unmuted?
Yes.
Okay. I'm going to try to summarize a little because we had a discussion of this, and I want to share that with you because it's actually one of the scopes here. It's the one we say establish definition and scope for end of life criteria, and so. The committee hasn't made any decision, but I can tell you sort of the feeling of at the prior meetings and actually other meetings that have happened around the state is that this is not focused on like hospice care and just the last weeks that have a serious diagnosis, like stage 4 prostate cancer, um, I think most of us, myself, would view eligible for that care at the time of the diagnosis. Again, there, that's not been written that settled in stone anywhere, but I think that makes sense. I personally wholly agree with you that this is really that you want people to be able to improve their mental state early on during the process. So I think that I would say that from the previous conversations, the committee is very supportive of what you're saying, which is to have it early on, and I think
Right.
that is what I suspect we'll wind up recommending.
Great. And can I make one more comment? Is that okay?
Yes,
Sure.
go ahead.
There is a study being done in Colorado, I think it's at Anschutz, about psilocybin and cancer patients. And I'm not sure if this is necessarily an apropos thing to bring up with this specific topic. And I was unable to participate in that study because I live in New Mexico. But I think, in my opinion, it's really, really critical that we get as much, mental, whatever the word is, calming and help as we can through this whole process, because it's really not a lot of fun. So that's all. Thank you. I appreciate you guys.
Don, I have a little bit of multiple roles here. I'm also a researcher at UNM, and I'm going to share with you that we actually have, it probably maybe will be the same study. It's called Rekindle, and it's predominantly for people with cancer and have had issues adjusting with mood or anxiety changes. It's actually using an injectable psychedelic. It's not psilocybin, but it basically is from the point of view that it breaks into psilocin in the bloodstream. And so that's here in Albuquerque. So if that's something of interest to you, you can, if you could, the study is called Rekindle. And if you Googled Rekindle New Mexico, you should get access to that. I'd like to maybe throw open a little bit to discussion. Any other people have comments on Don's issue that we talked some about the timing of eligibility? If not, we can move on to other questions. I still have an open question out there for other in-services that people would like to see through this committee.
And just as a reminder for everyone, if you're interested in speaking, all you need to do is go ahead and raise your hand. In order to do so within the system, within the team system, there's just if you're on a computer, there is a little hand icon that says raise underneath it, about in the middle of the screen at the very top. And if you're on the app on the phone, if you click on the three ellipses in the menu, and then the hand icon will appear and you can select it. If you are joining through voice only on a telephone, if you press *5, that will raise your hand. And then once that occurs, we'll call on you, and then to unmute, once your name has been called on a computer, the unmute is the microphone icon, and it is on the upper right area of the Teams window. And if it's on a phone, it's usually in the lower left of the Teams app. However, please be aware, some different models of phone may have the mute or unmute icon in a different location. If you are on a telephone for voice only, please press *6 to unmute yourself.
All right. Thank you, Dominic. And on that note, we have James Brown. James, I've enabled your microphone. Can you go ahead and unmute yourself and begin when you're ready, please?
Hello, everyone, and Dr. Leeman. Again, thank you for putting this committee on. My thoughts on this, sir, are, if we really could focus back on that ICD PIN code of the Z51.5, that was approved in the other committee. Sometimes early on is very important on this, Larry, that. And as a serotonin, based receptor that we're looking at here, that's intestinal. A lot of our serotonin is about 80% is intestinal, besides in the brain. And with that, release that we get for certain cancers, this is very important that we treat it early on versus late. So early versus late is going to be important, in those phases, and looking at the ICD-10 coding and how can we do that. I don't know if that needs to be a separate topic, Larry, but I think this is a great topic to get into for people, because as we treat different diseases, this modality is going to be used differently for each one, and we can establish those, I guess, that needed curriculum or that needed protocols as we get to that protocol phase, and we can look at that. But I think it's important to look at early versus, late, because sometimes, ceremonial is going to be important here. And I wanted to also bring that in. We've had kind of discussed that the last time. I'm not sure if that's, part of one of the other topics that's in there, was ceremonial versus traditional, in the essence of, of this use for the end of life therapy or cancer or whatever comes in there. So that's my thoughts, Larry, to start.
Thank you.
James, this is Larry. Thank you very much. I think the ceremony might come into the plan of care. That would be, so I think it is covered by what we have there. And I appreciate you're bringing up the early late. I think that and Chris Caldwell, who's going to be presenting a little bit later in this meeting, when I talked to her a day or two ago, brought up, there's going to be people that may benefit at multiple times. There may be people who are may benefit from the time of diagnosis, where they're dealing with that, and then if there is progression later on, they're closer to end of life. Maybe so it may be the answer to the question might be both times. Is Christine Caldwell on the call right now?
I do not see them in the list of attendees, Larry.
Okay, well, as we're discussing, I'm going to try to reach out to them. I sent her the link yesterday. I estimated that probably we would have some preliminary discussion and that she would probably start at 3:30, but certainly if we don't have more questions, we might. Um, I'm going to extract one more question out of James's what he talked about, because James, I think you started talking about coding, and I think you were starting to really address another area that that is going to be how is this paid for? How is what is going to be the funding mechanisms? What is going to be billable and what is not going to be billable? I know we have had discussions at the last meeting about the potential for the end-of-life care to potentially include a partner, a caregiver. I think that may be another thing that may be difficult to get covered. There may be areas like that that are potentially coverable by the equity fund. So those are just some thoughts for mine on the coding and all, but I'd be very interested in other people talking about that issue.
James, your microphone credentials are still enabled. You may unmute whenever you're ready.
Thank you, sir. Hey, Larry and everybody, if we go back in New Mexico, we need to look at what's the most commonly billed, coding around this, through the Medicaid and Medicare. Pull that data if we can and see if we can say, with that Z51.5, was is it is it something that I think it's going to matter? And if we could also get the state versus the demographics within the state itself, if we could get it, are a lot of these codings happening in Santa Fe, New Mexico, or are they happening in the rural community as well? Because that's also something, Larry, to look at and to address, is make sure we probably this is going to apply across the board to everybody, in the state. So I just want to make sure we're capturing all that. If we could get that data, I think it'd be important.
Thank you, James. I'm actually trying to contact our speaker here and see if there's been a technical problem or see where we're at.
Next up, requesting to speak. I'm sorry. I'm so sorry. Go ahead.
I have a text from her saying that registered twice and never received a confirmation or link to join. If I give her phone number, is someone here able to text her a link to come on now? How do you think we should handle this?
Yeah, Larry, if you can go ahead and send that on over to Johnny and I in email. That way we're not putting phone numbers in chat or anything. And then Johnny, if you could please reach out to her, I'd appreciate it.
Will do.
Next up, requesting to speak is Denali. Denali, I've enabled your microphone credentials. You may unmute yourself whenever you're ready.
Hi, committee and Chair Leeman. Grateful for the opportunity to address the board on this issue of affordability and how we're going to cover care. I think perhaps this gets the question of the equity fund and whether that might cover a caregiver or a loved one who otherwise would not be eligible for coverage. Something really important for us to think about when we're thinking about the equity fund is, right, that we definitely want things like the Medicaid population, that be a term of eligibility, but that's just the baseline. There are going to be so many other populations who we want to be able to access the equity fund. And I think that this example of auxiliary natural supports to the person who's directly receiving care is a really great example of the need for a more expansive definition within the equity fund for eligibility.
Thank you.
Johnny, you should have received an email with the phone number for Christine.
I don't see anything yet, but I will keep an eye out for a minute.
While we wait on that, next up requesting to speak is Trina Zoller. Trina, I've enabled your microphone credentials. You may unmute yourself whenever you're ready.
Hi, Larry and everyone. This question is maybe something that bleeds into another committee. And I don't recall if we've talked about it yet, but my question is about how a person who perhaps has a terminal diagnosis, but is being provided, they're getting their medical care from either an entity like the VA, being federal, wouldn't be able to make a referral for something like psilocybin therapy, or just a provider who doesn't want to endorse such a thing or wouldn't provide a referral to that. I'm wondering what you envision for the structure of this program, for where someone could go to get that referral from a provider who would be able to vet their medical information and such and be able to, certify, for lack of a better word, that they would be eligible for this.
James, your microphone credentials have been enabled. You can unmute yourself whenever you're ready, sir.
Thank you again. And Larry, when I look up some of the data, I remember, with my time with the Lung Association, lung disease is one of the most common, and I know it's one of the highest numbers for lung cancers, is definitely up there for New Mexicans dying and treatment of in our hospices. I know we see a lot of lung cancer. We see a lot of diabetes. Those are definitely health conditions that are the tops that I see besides hypertension, which again, as we discuss health conditions later, that'll be important. But if we go back and pull those other types of cancers, I think it'll be important as a group to go back and see, definitely some of these qualify already if they have COPD, asthma, emphysema, things that are very chronic lung type of conditions. Those people can definitely get treatment in different ways than some of these other maybe intestinal or specific organ, you could say diseases. And again, we want to stage those out. So if we do pick a disease state, let's say stage 1 through 4, commonly, and look at just the guidelines too for cancers, so that we make sure we're all talking the same national cancer stuff. And if that matters at all, I'm not sure if it does. But when I look up some of that data, that was just my thoughts on, at least initially, so we can start breaking down, what we're doing. That's all. Over.
Thank you, James.
Okay, and we're working right now with regard to getting the information that we need to for our guest speaker, so that we can see about getting that done. And I see that Larry is working on that at the moment. So is there anyone else who would like to speak on the topics raised so far? And I'll go back. Here's the 7 topics that were brought up in the last meeting. Established definition and scope for end-of-life criteria, therapeutic team development, inclusion of family and caregivers, sites of end-of-life care, education and workforce development, development of psilocybin-assisted therapy end-of-life care plans, and ongoing review and updates.
So we're making the connection with Christine Caldwell, and then she'll be able to come on. I'm gonna start doing an introduction to Chris with the hopes that she's on by the time my introduction ends. Chris was a former professor at Naropa, a therapist focused on somatic work. She's a leader nationally in end-of-life psychedelic care. Actually has a course that's well known, that's available. She's been a consultant with other studies, and I think she's a very valuable person to be sharing information. And as I mentioned, I think at this session she was going to, I believe, focus on the care team and the plan of care. But I'd imagine that Chris may be a good person for us in general to speak to. She, I mentioned Europa in Colorado. She actually lives in Oregon now, so she's had ties to both Colorado and Oregon, which are, both of the other states. So I think has information on both of those states. And in my conversation with her, has lots of very practical information about things like dosing and redosing and such. Johnny, have you been successful in sending her a link?
Not yet.
Larry, in the meantime, since we have a moment, maybe this would be a good time to set the date for the next meeting.
Excellent idea.
So that we're, the one thing we have requested, and this is just so everybody is aware, is, and I think most people know that our priority at the moment, because of the timeline of how long it takes to cultivate the medicine, is that our primary goal at the moment is to get those regulations completed. And so with that in mind, what we would like is to actually hold off on some of the other committees just until after session. And the main reason is so that we can focus on the cultivation and testing aspects while session is going on, because quite a few people, including many of you who are here as attendees to this meeting, get pulled into the roundhouse or into other legislative duties or support. And so we do recommend, or we are requesting, that happens at after the session. So with that in mind, Larry, is there a particular date that would work better for you?
Yeah, okay. So Dom, so we're basically talking about like in the first, not before the first week in February, if I have it correct. When does session end?
Session actually ends on February 19th. So we'd really be looking at any time after the 19th of February.
Okay.
That's a Thursday. So if you did want to keep the same time frame, I would recommend Thursday, February 26th. So that would put it at just about a month.
Yeah, it's fortunately not a good day for me.
Okay.
And you said the last day is the 19th?
Yes, the last day of session is the 19th.
Okay. Dom,
So,
would that day not be a good day at the last day?
yeah, there's too many things and items that happen on that day. Quite frankly, we would not be able to guarantee support for a meeting at that time.
Okay.
On that day. But any time after that. So that could include Friday the 20th or beyond that.
I'd like to propose Friday the 20th
Okay.
from 1 to 3 p.m.
Okay, that time is open currently. So unless there's any objections, if somebody has an objection, raise your hand, please. How does that sound, Larry?
Sounds good to me.
Okay, so we will get that scheduled for Friday the 20th from 1 to 3. So thank you. See, we will always figure it. Now, Larry, there is in the chat, there was a request to summarize some of the topics for people who could not attend. And I'll put that that slide back up on the screen if you would like, and if you would like to go ahead and summarize that. Here we go. Oh, and
I just finished talking to Chris Caldwell. She just got the link and should be coming on quickly. Apologies for I've been sort of trying to do that at the same time as chair of the meeting here, but if I believe I heard it correctly, there's an interest in summarizing the topics and the scopes and responsibilities.
yes, that is correct, Larry. And I've got that slide up, those 7 points that were created, and they were put in the chat earlier in the meeting.
Okay. I'll be happy to give my perspective and my recall on this. And as I say, hopefully Chris will be arriving at the meeting soon. So for the definition scope, that's really some of the discussion we had here, and the sentiments of the committee were that this is not like a focused on the very end of life in hospice, but that we were supportive of a relatively broad spectrum, which could be from the time of diagnosis. It also could, involve people that are reaching the natural end of their life through aging. So that was really all the sentiment. There wasn't anyone who was not in favor of that part of it there. The therapeutic team development, we talked about the advantages of a team, and the team could potentially include, a facilitator level of that would be someone who would be sitting with the person. Can have potentially a therapist that has, is a licensed therapist, could all potentially be part of the team. There's a sentiment that we really want to make sure that to keep this affordable, that if we can try to use that type of a team, that would be helpful. And we had a discussion that this may require the board to establish a role for a facilitator that could potentially be a licensed role. There's discussion that is within the scope of the board and DOH and would not need to go back to the legislator to do that. Inclusion of family and caregivers, and we touched briefly on that the idea is that this is different in a lot of ways, end of life, than depression, PTSD, and substance use, and that end of life is indicated that can potentially include caregivers and partners, and that would be a potential. We have started to have some of the discussion on how would that look, and the idea of coding that. And Denali had talked at one point about that this may be an appropriate use of potentially the equity fund to cover that. Sites of end-of-life care, the idea was to have a wide range, but that there was a sentiment throughout that often at home is the best place for end-of-life care, and to work on a way of making that available. Education and workforce development is kind of associated some with the the therapeutic team development. There's also some conversation, and I think Chris coming on the call is helpful in that there are actually places that people can get more focused training on end of life, and that the idea that hopefully everybody who's familiar in offering psilocybin therapy would have experience at end of life, but there may be people that's more of a focus. The terms being used now are things like psychedelic doulas, psychedelic chaplains. The development of the end of life care plan. We haven't had that much of discussion of that yet, but the idea is that would look at different models, like one treatment, multiple treatments, ways to support that. And then the ongoing review and updates is simply the having the idea that we would both get this committee and the public information about the studies that have happened so far. What have been the experiences? For instance, there's a fairly vigorous experience in Canada with Roots to Thrive of using psilocybin, so sharing that. So that would be my relatively brief summary of each of the issues. I'm sure I'm missing out important things there, so please, if people want to add in there, raise their hand. And again, checking, have we, Chris Caldwell come on?
Yes, Larry, I do believe they are. And Chris, I have made you as a presenter. You just need to unmute yourself. If you're not familiar on the phone, it's a *6 to unmute. But it looks like you've already done that.
I'm here. Yeah,
Great.
I am so sorry. You had just resent me that registration link, but I tried that several times and never got a link to join. So I'm bummed.
Well, Chris, you haven't missed anything. We're all here waiting for you. So we really appreciate you still being here. And I've talked you up a few times during the meeting, so people's anticipation is probably good.
Oh, great. Yeah, just like being told that this is the best movie you've ever seen. And then you go, what? What was that? Anyway, so do you want me to launch into what you and I chatted about the other day?
Oh, Larry, you're muted.
Chris, I think that would be great. We have spacious time here, so I think that you could focus on those issues, take some questions, kind of see where it goes. But we've talked about in general. We have 2 hours trying to have these meetings be about an hour and a half. So you could easily take up to 30 minutes and present, and that would leave us adequate time, I think, for discussion.
Well, I think what I'd like to do is we talked about sort of 2.5 of your 6 principles. And, that was like the therapeutic team, and I would say / workforce development. And then the other piece of that was, the plan of care. And I'll start with, talking about the therapeutic team. But I would like, if somebody has a question or a comment, if somebody could just flag it and I'll stop. But I first of all, I so appreciate this opportunity, and I'm so bummed. I guess for folks that don't know me, so Chris Caldwell, founder, executive director of End-of-Life Psychedelic Care. I'm just going to say we organize our nonprofit around 4 pillars. So education first and foremost. I do as much as I can free online events. We've had like some 6,000 people register for our events since we started in 2023. We have professional courses. So I spend a lot of time thinking about the kinds of things that you guys are now discussing and wrestling with. How do we best serve people toward the end of life? The other thing we do is we connect people together, either the professionals with each other, the consumers, clients with each other, or then with each other. Clients with people both experiencing end-of-life and psychedelic care. I also wanted to mention, because I think it's germane, even though if it's not germane from a psychedelic standpoint. So I'm just tickled to have received a grant through Healing Hearts, Changing Minds in collaboration with Legare, the Christian Psychedelic Society, and the Institute for Rural Psychedelic Care. We're going to be running a pilot across 3 sites, Northern California, Chicago, and Atlanta, pairing a palliative care physician with an end-of-life doula or a chaplain. So we're all about demonstrating the efficacy, in this case, of ketamine to reduce existential, psychological, even physical pain, distress, and with a spiritual model integrated into this. So when I think about what's applicable for New Mexico going forward, I think what we're going to be doing in building this protocol, even though it's using ketamine, could be applicable. Okay, so having said all that, and thank you, I'll start with this idea of your principal therapeutic team. And I want to start out by saying, when we think about this, and I'm sure you guys have already talked about this, so, it's not necessarily a psychotherapeutic intervention. It could be psychological, it could be ontological. I like to think of it as either a psychospiritual or a psychobio-spiritual type of intervention, if that's even the right word. Because now we're getting closer to, as you talk, as hospice talks about total pain. So we're really looking at, the ability of something like a psilocybin to be not just transdiagnostic, but also to help an individual through many, many different types of conditions. And in this case, yes, what they're faced with psychologically, physically, existentially, spiritually, as they're faced at this time of life. And so that's kind of number one for me as I think about this. And then, the second thing is we always talk about, or I think of it as a continuum. So, we talk about clients who are recently diagnosed all the way to being really close to the end of life. So, of course, as you have been talking about expanding that definition of end of life, well, then your plan of care, your therapeutic team, your training requirements will all differ. And that's also the good, because my hope is that, of course, is you really don't turn anybody away unless there's a really definite sort of physical or psychological reason. So, but it will be very different, obviously, depending on where that person is on that continuum. Similarly, if we're talking about in clinic or in hospital session and facilitation and integration preparation, that's different than in home, obviously. And so I'll come back to that one a little bit when we talk about plan of care. But basically, when I think about this too, another key factor here is that psilocybin therapy is different when you're working with people faced with a life-threatening or serious illness. So, and what I do is, I don't replicate, when I think about my educational programming, I don't replicate anything that's already being done out there. There's plenty of really wonderful psychedelic training organizations. So I come along and I augment. And as we have begun to get all this information, and I also collaborated on a psychedelic death worker study that I think some of you might have participated in, we've been able to gather a lot of information. And to me, it's along two main dimensions. One is, what is that client's mindset when they've been told that they have a terminal or life-threatening or chronic illness, and what are those practices that are then different, that you as facilitators, prescribers, clinicians need to know about in order to serve this very, very different kind of a mindset individual. So if I could share that with you first, sort of as a base level here, and then I'll have one more comment, and then I would love to kind of break and hear your questions, or even better, comments. So if we think about a client's mindset after they've been told that they have a terminal illness or they have cancer, and this is true even if people are given like 2 years to live, or they're told that their death is fairly imminent, that they go through these different states. So, first and foremost, a physiological state change. So not only are they faced with their ongoing disease process and the pain, their treatment side effects, the physical fragility that can influence their emotional, their cognitive, and their spiritual capacity. Of course, what's going on psychologically, they have that fear of dying, that anxiety, that depression. And I want to say too, some of you have listened to the conversation I had with Thomas Hartle. He was the first Canadian approved for psilocybin therapy through Health Canada. He had the benefit of 7 psilocybin journeys through the remaining time of his life, which was from 2020 to 2024. And he started with, I want to reduce the debilitating anxiety that prevents me from being with my family in the way I want to be. He started with that as his intention. He came back 3 months later because the anxiety started to return, but then he moved into a more existential consciousness and became basically a panpsychist, whatever it is, where everything is consciousness, where his cancer was consciousness. So if we have an ability to help people through these various sort of states of mind that they are now existing in and help them, it is so wonderful. And so it's not just necessarily a one and done. It's like, let's look at the total scale of what we are as humans. And if you happen to believe that we are all consciousness, to me, all the better. So in any case, from a psychological landscape, folks are now faced with guilt, they're faced with shame, they're faced with unresolved inner conflicts. Third, there is existential distress. What is the meaning? Why am I here? I'm worthless. They don't really have a will to live sometimes. Sometimes if they were the matriarch or the patriarch, it's like, I've lost my reason to be here. And then there are sociocultural realities. Big there, of course, are family dynamics. What is the family dynamic? What are those relationships? Are they supportive? Are they obstructive? Are they chaotic? And then sort of a relation to that is, that there could be caregiver fatigue. I'm sure all of you that work in this space know the spouse who just wants to take care of their spouse who's ailing. They get sicker themselves, actually. And so now you've got an individual who's dealing with guilt because of their spouse burning out, trying to take care of them. Then in terms of sociocultural, you also have, are there strong cultural or strong social supports, or is this person living in isolation? Then as another dimension, you've got, what is their spirituality? What are their spiritual beliefs? What do they believe about death? What do they believe about atonement? Do they think they're going to go to hell? So much is going through this person's mind. So what does that mean for us when we want to take care of these people? Goes right into clearly a greater need for collaboration. More often than not, we're going to require a medical clearance. And of course, as that person gets sicker, that person gets more physically frail, that becomes more and more important. We're going to look at dosing considerations as their body may become more physically frail. We may want to coordinate with palliative care teams, and depending what your specific role is as the facilitator, not just with physicians, but with therapists, with chaplains, with grief counselors, with doulas. Then we look at meeting that person where they are spiritually, so integrating spiritual frameworks into this whole process right from the get-go, and being able to assess where this individual is at and how you can honor that client's spiritual beliefs and needs. Third, working with families. I think this training should require a whole session on what it means to work within a family dynamic, because it's just so important, all the way from just basic education needing to be a part. And I know you have talked about including the family in terms of participating in their own journeys, or maybe participating in group journeys with the client. But, obviously that's a very personal decision between the client and the family. And there's plenty of reasons why it's not necessarily a good thing, but nonetheless, they need to be part of this whole process. Maybe they're just brought in for the preparation and integration, but they need to be a participant. And by the way, what do you as a facilitator do if you've got one adult child saying, no way, I ain't letting my mother go on a psychedelic trip? What are we as a facilitator going to do? Are we going to honor the client's wish, or are we going to honor the daughter's wish because maybe she's going to sue you. Informed consent takes on a much expanded sort of definition and role here. You may have to talk to your client about, yeah, you know what, you could die. You could die during this journey, or you could die shortly thereafter. We have to talk about expanded consent. Maybe there's a healthcare surrogate that needs to be a part of this. So a lot of transparency regarding risks. And another big part of this is assessing cognitive capacity and decision-making ability. So again, more training, more understanding of what informed consent must look like. And then, you know, another aspect of consideration for facilitators and for training is, what does preparation and integration look like? And I'll come back to that, but very important. You know, Larry and I talked about this a little bit. It's like, could be longer, could be shorter. Both on the preparation side and on the integration side. I certainly have heard a lot of stories about individuals who are very, very close to end of life. And their integration was pretty much, wow, that was great. No, that's not what it was. It was more like, I am at peace now. I am now grateful for my life. I now realize that there is no pain upon separating from my physical world into this other world that I'm going to. So there's a lot of considerations there in terms of building that container, understanding that, again, their needs, their mindset, their inner world, their intentions are very, very different. And then we look at energetic hygiene. And I generally speak in terms of this for you as the facilitator. What does that really mean? I mean, it's important, you know, for all of us who've gone through psychedelic facilitator training, it's important to learn about energetic hygiene for yourself. But when you're talking about working with somebody who's closer to the end of life, there can be energetic sharing that's beyond what you would normally get. You've got a spiritual discharge potential, a lot of energy discharge from an individual looking at the end of life for whatever reason. You might have entities come and visit you during a journey, coming to support your client. So what is it that you need to learn about energetic hygiene and taking care of yourself and preparing before, during the journey, and after. Another thing that has come up when we did our psychedelic death worker study, and in talking to a lot of people who've been doing this specific work for decades, is the complementary sort of integrative practices that go along with it. I don't know if working with people with a terminal illness just lends itself more to this, but it certainly seems, in talking to people that are experienced, that they bring in Reiki, they bring in meditation, they bring in guided visualizations or some gentle massage or yoga. And in many cases, you can get to a point where you say, you know what? We're not here to administer psilocybin. We're here to help you gain peace with your death and dying. So you know what? Psychedelics might not be a really great thing for you right in this moment. We're just going to sit here and do a guided visualization. So always need to have that in lieu of a psychedelic, to have those integrative practices, and or they're important during the preparation phase and or in the integration phase. One of the other things we always want to talk about, because it always comes up, is MAID-related clarification. So I will say, when we do our trainings, we never say, yes, we're going to give you some psilocybin followed by your other medications. But it's more a matter of saying, all right, and I have heard stories both ways where they have used psilocybin or ketamine and said, I already had, let's say they already had MAID approved. Then they decided that they weren't going to use their MAID. They were okay. there's this gentleman that he was on a panel I just moderated, has been living with quadriplegia for some 31 years and was ready to die because he was fine, but then the pain became excruciating. Something happened, and I'm sorry, medically, I don't really know what it was, but he wanted to die, decided he was going to use psilocybin in a church ceremony, psilocybin church ceremony, and literally fell in love, got a new lease in life. He literally fell in love, met a woman and fell in love. And so now he has no interest in dying. But then conversely, there's stories where an individual has taken ketamine or psilocybin and said, yes, this is what I am going to do. And they get peace or clarity around using the MAID. The other thing that I don't know what's going to happen in New Mexico, and so I'm really curious about this, but there's certainly a lot of potential for low dose work with psilocybin and ketamine for that matter. I personally love the idea of psilocybin microdosing support groups, whether that's for an individual with a terminal illness or cancer diagnosis, or a grief support group that would come together. And I'm not sure where New Mexico is with that. But in any case, then kind of bringing that back to this idea of what a therapeutic team should look like, can look like, and what kind of the development or training should look like. I guess I go back to pragmatic, and this is where I really want to ask you guys, because I don't know. But given what I understand, your current law is that the psilocybin administration is via a clinician, so a medical or mental health clinician, and I know that it's more broad than that, and that I think one of the things you are all working on is trying to broaden who in fact may administer or maybe be as part of the team. But I'm thinking in the very near term, since I'm assuming that that you're going to be able to start dosing sessions in 2027, early 2027, then looking at the therapeutic team that has been sanctioned by SB 219 would mean it's a clinician that would need both psychedelic training if they don't have that, and then I would argue specific end-of-life related training in addition to that. Ideally, then, there would be individuals who maybe aren't able to administer, and this could be end-of-life doulas, chaplains, I suppose that's because I guess hospice social workers, hospice nurses, they would all fit under the clinician role or definition. But in any case, to be able to train individuals who understand what it means to work with somebody who's dying and actually has sat through transitions, which is just amazing, and then be there as part of a therapeutic care team would be great. So, I think also when I think about the therapeutic care team, and you've got your prescribers, and I'm not sure if your prescribers are necessarily then going to also be the practitioners or the facilitators, but in any case, I think there needs to be training for the medical screening, say, in addition to training for those that will be doing the facilitation. Because I'll say that the training that I normally do is for the facilitator. I do one ketamine training that is specific for the prescriber, so the physician or the nurse practitioner. So again, there's overlap, but there's also some distinct areas of training that a facilitator wouldn't necessarily have to do. So I hope I'm not rambling too much, but I guess one other thing. I'm sorry, I'll stop there.
Oh, no, Chris, I just wanted to let you know that we do have somebody who has a question. We have James Brown, who's got his hand up. James, you are
Yep.
enabled. Go ahead.
There we go. Thank you. Can you guys hear me?
Yes, sir.
Yes.
Catherine, thank you so much. I just had one or two questions for you. Amazing. I really appreciate your knowledge and info. First and foremost, my questions were around the facilitator and with those administration sessions. Were you guys doing a non-directive approach, or were they using a semi-directive, non-directive? And then did you guys have them? I'm sure there was some type of client release form there in that specific plan that they were using per person. Can you explain that a little bit more and go into that detail?
Let me take the first one, the first question, and then you might need to repeat the second part of that. In terms of non-directive, that is such a great question. In the states of Oregon and Colorado, as a non-medical model, it is purely, we purely teach a non-directive approach. And I'm hesitating because there are, to me, there's times when there should be interventions, and you really, again, need to meet the client where they are. I like client-informed therapeutic approach sometimes. Now, but I also will say, if we're talking about the preparation, the set dosing session, and the integration, the dosing session primarily is non-directive, but when you start to see a client become agitated, and you feel you need to intervene, then yes, there are ways that are more non-directive. There are things that maybe are more interdirective, just a little bit different. I don't know that I'm answering your question. I hesitate because I never would like to say it's all this and it's not something else, because depending on where your client is, if your client believes they're really dying in the moment, you're going to intervene. And sometimes just saying, no, you're not going to die is not going to cut it. So there's times for interventions that I think are really important. But generally speaking, you're inviting that person to have their own journey. But then I can tell you other times, and I love to tell this story, again, Colorado, Oregon, non-directive model. But I don't know if any of you know Hunt Priest with Lagare. He was one of the clergy members that participated in the Johns Hopkins research back in, was it 2019, 2006, whenever, I think it was 2019. And Hunt tells this story himself where he felt an electrical pulse in his thigh. And he was getting, I don't want to put words in his mouth necessarily, but I'm going to say he was like getting agitated. And the facilitator literally put his or her hand on his throat chakra and released that energy. And Hunt describes it as a Kundalini experience. And it freed him, and it really was an epiphany moment for him. Now, that was a very, very well-trained facilitator that did that. But I absolutely love that story because non-directive may not just always be the answer. So that was a long way of answering your question, James.
Oh, it completely did, Catherine. And I'm a big believer especially end-of-life therapy, that sometimes you need to use redirective. And, and that sometimes would be like we've been taught, like I've been taught before with the hands, feet, and head, that you can do certain touching that's been agreed upon pre-session, and that, that preparatory work, like you've been saying, is very important. The state and some of those expectations are set so that person, and I'm glad that you've answered that. Thank you so much. That was my question on that.
So what was the second one?
In your studies that you guys did, and were practicing those journeys and experiences and healing, were those in more of the set and setting? Was that a building? Was that somewhere that you guys did in a retreat setting? Was that something that was only indoors per se?
Well, okay, so I gather stories from hundreds of people, so I don't necessarily look at just what we did this one-off time here or there. So, and my educational programs are for anybody, whether they work underground or not, or with whatever medicine that they use. So it runs the gamut. There's been in clinic, well, let me put it this way, in licensed service centers in Oregon. Then there's a retreat. There's the Survivorship Collective, which was a nonprofit which was founded to organize group psilocybin retreats in Oregon and Colorado, wherever they're state legal, or like in the Netherlands, for example. They have the benefit of being on a property where they could actually go outside, at least after the journey. So there was a sort of blend of indoor, outdoor. Of course, underground, I know people who do it in any number of places, including outdoor, generally speaking, in the individual's home. That's where most people like to have psilocybin delivered, is in their home. And then the pilot that I talked about that we've gotten funding for, that will be an in-home ketamine therapy administered intramuscular IM. So there's that. I will just say I'm a big fan of groove models, which is why I'm going to be really interested in Larry's work. The retreat that was developed in Portland, Oregon is amazing. I mean, they do four prep sessions. They come together for, I think it's 2 psilocybin sessions over a 5-day period of time, and then they've got at least 4 integration sessions. What we see with people, and these retreats are designed specifically for people with cancer. What we see with those kind of group models is a real bonding that enhances, deepens, extends the therapeutic benefit, no question in my mind. I'm a big Roots to Thrive fan who developed the group model in Canada when Health Canada first brought that psilocybin therapy forward. I also want to mention, when you talk about touch, because it's something obviously that you guys will talk about as well in terms of training and what will the state of New Mexico allow. So, in Oregon, you do the shoulder, the feet, the hands, and hugs. In Colorado, you do the feet, the hands, the shoulder, no hugs. I also owned and operated a pretty significantly sized home healthcare agency back in Florida. And so I really understand helping individuals who are aging in place. And, in terms of touch, one of the things our home healthcare aides always did, not always, they always offered, but pending, of course, the condition of the skin, rubbing lotion or oils on the shins, and on the forearms. I almost said foreskins. That would not have been good. Okay, so on the forearms and on the shins, rubbing oil or lotion, and it's just so soothing for an individual. So anyway, that's a whole other issue.
Catherine, thank you again so much for that. I mean, that's what I was asking about, and you answered it completely. With my experience, I think it's important that this committee and this advisory board look at options for people at end of life and the various different settings for the various different ICD-10 coding that we're doing. And potentially, in my experiences, allow for certain safety, of course, but allow certain things to occur, as long as it's agreed upon up first in those plans. Thank you so much.
Yeah. So what do you think, Larry? Should I keep going?
Chris, I had a question. You and I talked some about, dosing with folks who are with more advanced cancer and others. Do you want to share some of that with the group?
Yeah. So, this kind of goes back to what are the protocols then and the care plan going to be for working with somebody toward the end of life. Again, understanding that there is this continuum of like being newly diagnosed all the way to very, very close to the end of life. So, you know, one of the things we talk about, and I have this chart, and it's a rough dosing guide. And it's always, you know, you say a rough dosing guide and you always get into trouble. But nobody likes to talk about what the dosing actually might look like. So one of the things I do know I want to say is that ketamine, we feel, can be used all along this continuum. And certainly some of the stories, the story where I talked about a gentleman who actually used it to decide on MAID was very close to the end of life, and it was ketamine. It was ketamine at 0.7, 0.8 milligrams per kilogram, so it wasn't like it was some kind of lightweight dose. Psilocybin is really great also throughout this continuum. You just need to think about different dosing levels, but there's so much that's going to go into this into the factor of dosing. One, of course, is how psychedelically experienced are they? If they're naive, so let's start with that, you know, and let's say they're still on the end where they're fairly close to just being diagnosed, then, you know, starting with maybe 10 milligrams, starting with maybe 20 milligrams, maybe starting with 10 and then going for a booster for 10. You know, if it's a physically healthy person, I think a lot of times people can start with 10 and go to 10, maybe 20 and go to 10 as a booster. But the other thing to keep in mind is that as the body becomes frail, then metabolism shuts down. And I shared with Larry a couple stories where one person was put into the taxi cab because nothing was happening after several hours, and their trip started in the taxi cab. Or maybe it was Uber. But then the other story where a person was given, I think it was like 20 milligrams out the gate, maybe it was 30 milligrams out the gate. And in Oregon, the max is 50 milligrams. Nothing happened for hours, a couple hours, and gave him another booster. Nothing happened for hours. The gentleman got to the max 50 milligrams. Several hours later, all hell broke loose. There was like vomiting and diarrhea for a very long period of time. So it's like, you know, I have a hospice physician who's been doing this work, or I know a hospice physician who's doing this work for a very long time. She'll say, you give them a dose and you don't give them anything more, even if there's no trip, you know, come back on a different day maybe. Her philosophy is that person is not prepared enough. So there is that as an aspect of it. Certainly when they're really close to the end of life, and I mean like within a month or weeks, looking at something like a half of a gram, well, excuse me, that would be 0.5 of 0.5, 5 milligrams versus 10 milligrams, and maybe another 5 milligram booster would be okay, because again, now this person is half on the other side already anyway. So, and we believe they're already in a sort of psychedelic journey without even any psychedelics. You know, this individual, they're at a point where they're having deathbed visions and they're having conversations with their loved ones from the other side, and arguably they don't need any psychedelics. But then I would say a very, very low dose. And you know, Larry, the answer to that question is always it depends. But I like maybe 10, maybe 20, followed by another 10, followed by maybe another 10. Short answer.
And
Chris,
my
thanks for
apologies
answering
interrupting. We have a question or request to speak from Don. Don, I've enabled your microphone credentials. Will you unmute yourself and begin when you're ready, please?
Thank you. Can everybody hear me? Hello?
Yep. We can hear you, but very minimal.
Yeah, hold on. I apologize. Ma'am, I really appreciate your information is amazing. I like it. You don't have any way to, like a website or anything that I can look into you more? a way to contact you. The things you were saying is really up my alley, the spiritual side of this and all of that. But the question, or I guess comment that I have is, if somebody at what, and I'm kind of asking this twice, but you weren't connected yet. At what point do you start to administer this medicine if somebody has cancer? I have stage 4 prostate cancer, but I'm in treatment and the pharmaceuticals that I'm taking are working. So I'm not very sick. I'm mentally and emotionally sick. So I'm not sure, how do we go about, like, you go in and talk to somebody, and could we just take some of this medicine just to help us cope with all of this? This a massive amount of stuff we have to do, or do you wait until I'm sicker to start to administer this medicine, or what's your thoughts on all that?
Well, I would say that best would be to start whenever you feel called. So there is no need to wait. Yeah, there is no need to wait. And earlier I was sharing just a little bit of the story of this Thomas Hartle, who had 7 psilocybin journeys. So he had been diagnosed with stage 4 colon cancer in 2016. And, Canada didn't approve this psilocybin therapy until 2020. And like I said, his anxiety was debilitating. So, he was the one that did the outreach and went to where, asked to apply to this new program. And over the course of those 7 psilocybin journeys, he really evolved his intention from being a psychological one having to do with anxiety, all the way to then more existential and spiritual questions about, who am I, where am I going? And so I would say if you're in a place, or you can come to Oregon or Colorado, in a place to get with individuals who are trained to work with people with cancer, then I would say do it. Do it now and then do it later. And yeah, Larry said he would give the information about my website, because there is the conversation I had with this Thomas Hartle is something that I think everybody should listen to, because he does an extraordinarily eloquent job describing the arc of his 7 journeys.
Thank you. And just for clarification's sake, Kate Hawk was gracious enough to post the link to that website, Don, so that is available in the chat. Just to catch us up to speed, Asher Weinstein in the chat asked, are standard dosing metrics milligram per kilogram? So Chris is saying 10 milligram kilogram, then redosing with the same. Lawrence clarified 10 milligram synthetic equivalent, not per kilogram. Kate Hawk commented, right, the milligram per kilogram was for ketamine. And Asher's retort was, thanks, so it's not transferable to dried mushrooms.
Well, okay, so Kate, yeah, what I said about 0.7 milligrams per kilogram, that was for ketamine, and as a weight-based dose, which isn't always what's needed. The psilocybin, yeah, I was trying to speak in terms of the analyte. So 10 milligrams would be the equivalent of 1 gram of dried mushrooms, approximately. Let me say approximately. So I do have just a couple of more comments, but we've kind of touched on a lot of these things. But in terms of pulling it together, and Larry, when you and I talked about a care plan, and a care plan obviously is very customized to that individual. one of the things that I think a lot about, and now as I've told you, I used to own a home health care agency, so I think about what safeguards should be in place for in the home service. And I really like the idea of a medical screening being required, and that medical provider, prescriber, determining the care plan, because it's going to be so different for individuals. There may, you know, if a psychotherapist is now licensed to serve psilocybin in the home, for example, but maybe they need a medical person on site with them, then I think that needs to be determined up front. That, of course, would add to the cost. But generally speaking, you know, if you start with that intake and medical screening to determine the health, relative health, and potential for any drug-to-drug interactions or other contraindications, and develop that plan of care for that individual. I think what's really important is, and I don't know if this is going to be part of the New Mexico model or not, but to do assessments. When I say assessments, sometimes they can be in the form of a survey scale, self-administered scale like the PHQ-9 or the GAD-7. In this ketamine pilot that I'm going to be doing in collaboration with the palliative care physicians, we are using the PHQ-9, the GAD-7, the demoralization scale 2, and the facet, the spirituality questions on the facet. So trying to get at the spirituality component of these individuals. But nonetheless, this is where I think there may be a need for more preparation sessions as you're talking to an individual through their psychological, their physiological, their existential, sociocultural, and spiritual issues, getting an understanding of where they are at and where it is or what it is that they want from the psilocybin journey. And in a lot of cases, you know, you can't just be handing these folks these survey scales and letting them self-administer them, especially when you're really trying to understand what are your beliefs around death and dying. Are you afraid of dying? Are you afraid you're going to hell, like I had already said? So there may be a need for multiple preparation sessions. Certainly, I would also recommend that if there's an in-home session, that there's an extra in-home safety check. That will include a lot of different things, not the least of which is no guns that aren't locked up. So an in-home safety check that is not just safe, making it safe for the client, but it's making it safe for the facilitator. So that's an additional step I think that people should consider. And then I don't know, Don, if that was used. You alluded to, you know, when you have cancer and you have medications and treatments. So it's like, all right, determining when the psilocybin session would be best. And by the way, you know, I've read where people undergoing chemo treatment should wait 2 weeks following chemotherapy to do psilocybin. On the other hand, this same gentleman, Thomas, tells the story where he preferred psilocybin sessions 2 to 3 days before chemo. He didn't need the anti-inflammatory meds. He felt that it reduced or eliminated his chemo brain effect. He was able to actually help other people because they would have the chemotherapy in a group as opposed to being miserable. But he really felt it helped him go into chemotherapy with a better attitude. This man had 84 rounds of chemotherapy before he died. So anyway, so there's that as well. There's other, you know, the medications. For example, it's better to for an individual to be on a long-lasting opioid than on a short-lasting one. You know, because of this is psilocybin with a longer journey. For example, do they hold if they're on Seroquel or something for insomnia, do they hold that dose? Do they not hold that dose? So a lot of considerations like that need to be taken into account, which also could impact dosing, by the way, right? If a person is on an SSRI, you might want to increase that psilocybin dose. Really, a lot of attention is going to be paid to, is this more of an ontological type of therapy, I don't know if that's the right word, versus psychological, but being aware that the psychological could turn more into an ontological one. There could be spiritual distress, there could be spiritual emergency that arises as well out of this. And in preparation, I think it's really important then to be able to practice a lot as far as how can this person self-regulate? I mean, most of us don't. I mean, most of us who are now in this space might do it more often, but most clients, most people do not know how to self-regulate. And I think that needs to be practiced. It's not just a one and done. And then I think too, a consideration here on a care plan is, as physicians, I think many of you in this work do the physician order, physician orders life-sustaining treatment. So the POST plan that you would probably have to fill out for these individuals. So another consideration for you. And then in an integration part of that plan is, what is that follow-on support? You know, is it going to be an end-of-life doula, a chaplain, or a family member, or another member of the community to support this individual ongoing? So I'll kind of stop there again and just see if there's any other questions or comments. I'd love comments in terms of what you see happening in New Mexico.
So in the chat, we have a comment from Trina. She says, "Thank you, Chris, for sharing your expertise with us. I have to step away for patient care, and I'm sorry to miss the rest of your excellent presentation."
Oh, thank you, Trina.
I believe your credentials are enabled, Lawrence.
Great. Chris, thank you so much. That was an amazing presentation. And I certainly think it would be great to have you back, you know, at another time as we're moving along on our process. I wanted to share both with you and the committee that at the next meeting on February 20th, we're going to have a speaker from the committee, Jennifer Ketma, who's been in the role of psychedelic chaplain. And so we're going to have some focus on what Chris was talking about, which is the role of spirituality, spiritual advisors. So that will be on the February. And then the issues about dosing and stuff, I think is one of the areas that James Brown has been kind enough to offer to talk. So I'm hoping in March we'll be able to set that up so that we'll have follow up to some of these topics that Chris has opened up. Anybody else have any more questions for Chris? Chris, in addition to hearing all our thanks, we really do appreciate all the wisdom you shared with us.
No, I appreciate the opportunity. You know, as an invitation, you know, if you do check out the website, there's I'm doing a 90-minute presentation on an overview, and I go through the latest research. I've spent a lot of time updating the presentation. I talk about ketamine, psilocybin, and MDMA, the latest research that extends beyond when we talk about existential or psychological distress. And that's another thing, Larry, when you're talking about end of life and expanded definition. I love the work that's being done with Parkinson's, with MS, with ALS, with stroke survivors. So a lot of stuff going on in the psilocybin research world that's fascinating. So that's coming up in February. And then, as I talked up front about this really being at least a psycho-spiritual model, we've reformulated a lot of what we do. And as Larry knows, so we're doing a course coming up where it'll be some of the folks that are really steeped in spiritual practices will be teaching the courses, and I'm really excited about that.
We do have one more hand raised in the chat. Back to James Brown.
James, I've enabled your microphone whenever you're ready, sir.
Just one more question for you. Sorry to, and again, thank you for your time today and answering my questions. With this, earlier you talked about with the preparation as well as integration phases. Were those done in a person-to-person settings that your experiences gather, or were they virtually? Because in New Mexico, we're going to have some challenges with our ruralness and how we can provide services. So I just wanted to kind of talk about that and expand on that conversation just quickly on.
Yeah, boy, that's also a really great question. To me, ideally, in person is always better. It doesn't matter if the individual is closer to the end of life or not, faced with a terminal illness. However, like you say, if you've got folks in rural areas, then that may not be available to them. This could be, though, where, having a care team really can help. And again, I'll go back to this idea of pairing. In my case, it's pairing a physician with an end-of-life doula, but pairing a clinician with an end-of-life doula or chaplain who may be able to go out in person and be with this individual to help with the preparation. In our pilot, we're going to be having the doula do the initial intake, then the physician will do the medical screening. But James, it's more important, I think, to be able to get the help where they are than go, oh, well, we don't have somebody that's there locally, so we can't help you. And certainly, most people now are quite used to Zoom or whatever, speaking virtually. And so I think that's quite fine. It's just not as good.
All right, next up we have is Barack Wolf. Barack, I've enabled your microphone credentials. You may unmute yourself whenever you're ready.
Let's see if you can hear me.
Yes, sir.
Are you here? Okay, thank you. Well, appreciate the session. I think it was Trina who early on raised an issue that I think is relevant to a number of the comments we've had since then, but it's never sort of been approached directly. And that was, as we go through the various issues that have been raised and make progress on them, and it's wonderful to hear some of the in the weeds discussion that we've had today. An issue arises about how will folks, know about this. I think the question was, if my doctor or my hospice isn't knowledgeable and or really doesn't kind of believe in this, but I might be interested, who will I go to? How will information get out to the public? And it kind of relates to the rural issues, but, speaking from our medical aid in dying law and the implementation over the last 4 years, and I'm with End-of-Life Options New Mexico, it's an enormous challenge for people to learn about all of these kinds of options as we approach end of life, as well as access the resources to perhaps take advantage of them. And, it sounded like our speaker is part of a nonprofit that kind of fulfills that role for Oregon and provides that kind of information and referrals. And it's just something I think, Larry and others, that we want to think about. Will DOH play that kind of role once this gets up and going, or is there some other organization that would make sense so that people don't have to struggle to understand what this is all about? Thanks for listening.
Thank you, Brock. And this is actually Dominic from the Department of Health, and I'm putting in the chat right now the Training and Education Committee meeting, which actually meets tomorrow afternoon between 1 and 3. And those are some of the questions that that committee is going to be tackling, and how that training and education is going to get out, plus as well just information in general about the program. And the department, of course, will be doing some of our own as well. So just so that you know, that is one of the things that is up and coming, but we have to make plans for it. So thank you for the question. It's a great one.
Thank you. I'm so sorry. Just to catch up in the chat, Lawrence posted next meeting of End-of-Life Committee is February 20th from 1 to 3 p.m. Jen Clemente commented +1 on the demand generation challenge. And thank you, Dominic, for posting Friday, January 23rd, 1 to 3, training and education, and Brenda Burgard is the chair. Lawrence, before I move over to Jen Clemente, did you want to go ahead?
Oh, Mark, you're talking about a group, but I just want to shout out to your group that has actually been very active with End of Life and helped support the bill. And that, I think a lot of us would love to look up to your group to help distribute information about the role of this therapy. Barrick is part of End of Life New Mexico, which is a group that was one of the supporters during the testimony on the bill.
Barrick, your microphone credentials have been enabled.
Yeah, I got it. I got it. And I'm just going to say it because I feel it for the last several meetings. This is a difficult environment to try and really have conversations. I mean, it's just difficult. It's clunky to sort of keep unmuting and muting, and we can't see people. So it just makes it more difficult. And I'm sure there's lots of folks on these sessions that would more easily be able to contribute if it were an even easier environment. I just had to get that out. But thank you, Larry. I don't know to what degree. We have our hands full in trying to work with medical aid in dying, and we don't have a lot of knowledge about psilocybin. Some of our providers do, and some of our volunteers do. But overall, it's going to take a lot of education. And I guess, Dominic, I had thought that education and training was really around sort of provider issues. But I think you're suggesting that it also perhaps is around public education and outreach, which I did not appreciate. Again, you guys have a lot going on, and it's going to be hard for some of us who have some related interests to keep up with it all. I'm just saying that. But I appreciate the invitation, and I'll try and copy that and see what tomorrow brings. But I'm glad you're going to be addressing how the public is going to begin to absorb this new reality.
And just sort of to answer that a little bit, Barack, is two things with it. With regard to, we agree that in-person meetings are necessary. We're just right now, especially during the legislative session and in the winter, this is the best option to ensure that there's representation from all around the state and not just from local areas. For example, the storm that we're all getting warnings about coming through here in the next couple of days. But for example, some of the other committees are already looking at in-person and or hybrid, because we still want to allow people who are not able to travel to be able to participate. So we do recognize that. It's just the unfortunate timing of time of the year. The other aspect is, so the training committee is looking at providers first, but then once those criteria and everything are done, training doesn't stop just with one particular group of people. We need to figure out how do we get out there. And that's part of why when the bill was originally done, it had that December 27th timeline, so we would have time to get more information out. So it will be an ongoing process. And we do appreciate there is a lot happening. There absolutely is. If we could duplicate some of what we've been doing with about probably 3 or 4 times the number of people, we still would have more topics and more areas to deal with than there are people and time. But with that, with regard to time, because we do only have a little bit of time, and Jen has been very gracious and waiting patiently. So I'm just going to go over and say, Jen, I think it is your turn, and I'm going to shut up for a minute.
Jen, your microphone credentials have been enabled. You can unmute yourself and speak whenever you're ready.
Thank you so much. Thank you, Dominic. So as some of you know, I wear a few different hats. One, I'm really interested in chaplaincy. I've worked as a chaplain. And so my perspective comes from having to, trying to push, I guess, educate, make aware of this issue within my own hospice organization in Sierra County. And so now putting my marketing and communications hat back on, one thing that I really, always advise my clients in the consulting work I do is to find the persona, find the person who owns the decision, who makes all the big decisions. And so when I approached hospice around educating them around the Psilocybin Medical Act back in April, May, June, the answer came back, we don't do anything without the direction of our medical director. So if I might make a suggestion, it might be in both, we have to cross-pollinate interests between this board and the Training and Education Board and come up with ways to message and create programs or education for the medical directors of the hospices to get the word out. That might be a lowest hanging fruit, if I might use that cliched term. But yeah, medical directors would be my first line of persona to reach out to. That's all I have to say right now.
Thank you. I'll hand it off back over to you, Lawrence.
Great, thank you. I just wanted to, as a follow-up to Barrick, there is a lot of interest in the committee in having an in-person meeting, and Dominic and I discussed that. My thought is we'll probably do that in April when the weather is a little more reliable for people to travel. And the way we would do it is we would have the meetings set up wherever we chose to do that, whether that was Albuquerque, Santa Fe, or somewhere else. But we would have it hybrid so people could participate. But I think a lot of us agree that this can be easier in conversation than in the little electronic talking squares that we're dealing with now. So we do plan to have this committee have an in-person meeting.
And
so
I'm so sorry. I was just going to say, Jen Clemente in the chat, takeaway, target hospice medical directors for any outreach and input, perhaps a targeted survey.
This is Larry. I just want to thank everybody. This has been a great meeting, between Chris and all the conversation, and we're getting on 2 hours. So unless there's more comments, I think we could wrap it up here at this point in time. We do have a meeting February 20th. Jen is kind enough to offer to do a little bit in service there on the spiritual psychedelic chaplaincy issue. So we'll have that, which will be the day after the legislature closes, and then we'll look forward to planning some in-person meetings. So thanks everybody for all your great comments, and again, Chris, thank you for coming to join us.
And thank you, everybody.